Hello, this is my peer-graded assignment for the Coursera project Human Factors in AI. We will be discussing a solution known as a stroke predictor today. We will go through the problem that I'm looking to address today, a task analysis of the problem, what sort of key components are there of the user experience design, the privacy considerations that need to be made, as well as the ethical considerations of this particular solution. So what problem are we trying to solve? So here we're trying to solve the problem of people suffering from strokes. Strokes are one of the leading causes of death for Americans. Every 40 seconds, someone in the US has a stroke, and every 3 minutes or so, someone dies of a stroke in the country. So the hypothesis is by predicting the likelihood of a person having a stroke based upon their medical history, we can identify individuals that are at high risk. If we can do this, we can enable proactive prevention strategies. This will allow timely interventions, personalized healthcare plans, efficient resource allocation of my staff and resources, and ultimately a reduction in stroke occurrences and overall improved health outcomes. Let's take a look at the task analysis of this as it's done today. So the user we're talking about a clinical health manager of a health system. And what they're trying to do is they want to identify and communicate with patients their risk of suffering from a stroke in the future. So how's this done today? So today, if it's done at all, there may be a decision to periodically identify at-risk candidates for stroke or for other common health conditions. This would require a manual review of the patient records. The user would use a report tool or even a manual chart review to determine which patients are at higher risk of suffering from a stroke. They would then need to consolidate the at-risk patient contact info, and they could use a spreadsheet for this. At this point in time, they would then communicate the risk to the patients that had a higher risk, and they could use either patient secure comms, they could use phone calls, other ways to communicate with the patients. And then, of course, the objective is to inform the patients of their higher risk of stroke and suggest next steps to avoid having a stroke in the future. So what are some of the insights that we get from this task analysis? Obviously, it's a manual and labor-intensive process. This has got to be manual review. The putting together of the contact spreadsheets manual. Obviously, there are limitations on the number of patients that we can actually do this for. It may not even be feasible for us to rate the risk of stroke across the entire patient population, and we may have to filter it down before we even start the process of determining the risk of stroke. Other challenge is the heuristic determination of what determines your risk of stroke. This has to be proposed, has to be validated and implemented across the board. So what are the key factors in determining that you are at high risk of stroke? This has to be determined. And then obviously it lacks scalability to be able to regularly do these reviews as well as communicate out. And as the patient population increases for the health system, this becomes even more and more difficult. So let's take a look at the user experience design, the key elements there. First of all, I want to talk a bit about improved workflow. And so here what we're talking about is having a regularly scheduled processing of patients to establish their risk profile for stroke. They will do this by running a risk profile report. This will be a report tool that's utilizing the machine learning model as it's running. The output from this will be a list of scores for the entire patient population that the reports run for. And this score can actually be implemented into their patient profile in the EHR. From here, we can communicate the risk scores out using a patient portal, other secure communication channels. So these risk scores will be actually sent out to all the patients to let them know if they're at risk, and also kind of the degree of risk as well. So it's not going out to just the patients that are at high risk. It's actually going out to all the patients to let them know, even if they have a very low or no risk of stroke, that they'll also get a score as well. And the objective here, again, is to inform patients of their level of risk for having a stroke in the future. The user inputs, the data we're going to be focused on using here will be the historic data that's already located in the EHR. This includes demographics, health history, family history, all the important pieces of information that would go into determining if a person's at high risk. The patients themselves, existing PHI data permissions allow providers to utilize the data for treatment purposes. However, since this is for prevention purposes, we would need to inform the patient population of the program and then let them opt in if they're interested in receiving a stroke score. The patients would also receive, when the patients receive their risk score and their recommendation, we can expect them to also action accordingly, and the practices will need to be ready for that. The clinical health manager's inputs would be interacting with the reports module to regularly schedule the report runs, to initiate another round of scoring, and then also to initiate the communication of the score to the patient population. And finally, to also be able to be ready to receive the patient's communication back in on what action they want to take based upon the risk score. On transparency, we want to share with the patient the information around what historical data was utilized. So this will include what information from their medical record was used to determine their risk score. We need to explain the concept of risk score. What does the score mean? What do the different ranges mean? Also, how do they need to interpret the risk score? We need to explain the attributes of the factors, or the determining factors in layperson terms. So we need to explain to them, for example, if they have high blood pressure, explain how high blood pressure can be a precursor to a stroke. We also need to talk about any limitations that we have in the model, and that we need to explain clearly that this doesn't mean that this is a probability of having a stroke in the future and not a guarantee of having a stroke. On the uncertainty element, we need to share with the patients the potentially probabilities of other with similar attributes that may suffer from a stroke. So we could show them buckets of other people who also have similar attributes that would fall into a similar probability. Well, of course, we wouldn't show other people's protected health information, but this is more of a population metric. There's also a lack of precision of the time frame of when someone may suffer a stroke in the future. You need to make sure that the score ranges are fully explained so that everybody understands whether they're low or no risk of a stroke versus someone who's at very high risk of a stroke, and everybody in between. We have to explain that score range. And then we, of course, need to also share any limitations of the model that would potentially impact the score. So what privacy considerations will we have with this solution? Obviously, HIPAA is a big one. Since we are dealing with medical patient data, this is also obviously very sensitive. In this case, we would actually be a business associate to our customers. They are the healthcare providers, and they are covered entities under the law, but we would be business associates. So what does this mean? As I mentioned earlier, the existing PHI data permissions allow the providers to utilize data for treatment purposes, payment, and operations. And every patient will have already signed off on these permissions before they receive any treatment. However, since this is for prevention, we need to get specific opt-in permission for the patients before we include them in the risk scoring exercise. As I mentioned, the data is PHI and is personally identifiable. All interactions and access to and use of the information will need to be safeguarded by appropriate identity access management controls and appropriate privacy monitoring. That being said, there are existing requirements for health providers and their use of EHRs that have sufficient mechanisms in place to comply with the privacy regulations. What ethical considerations do we have for this solution? I think we've got some potential sources of algorithmic bias, including historical bias. This data was entered by clinicians and by staff members, so there may be assumptions made along the way during the documentation process that could have unintended bias between attributes they're using this in for the score. We could also have measurement bias. There is really an inexact relationship between the various historical health factors that we're considering, and the features could be a weaker proxy than we would prefer to have for what we're trying to measure. Finally, there could be a learning bias. Certain features like social determinants of health may amplify performance disparities across groups. It could lead to certain biases based upon socioeconomic or other things that are not intended for the model. On fairness, I feel like that we've got a good fairness element here. We're including the entire patient population, so everyone has equity of opportunity to opt in. And for patients who may be excluded because they don't use a patient portal, we'll make sure to have phone calls as an alternative way to communicate the risk score. We'll deliver the risk score to everyone who's participating, and we can deliver this via the secure patient portal or a phone call. And then we want to make sure that we have fairness and equally being able to support all patients who look to action based upon the risk score. On the accountability front, we want to clearly inform patients of how they can provide feedback on the risk score or the information used to provide it. So we need to give them a feedback mechanism. And of course, we need to allow patients to opt out if they decide they no longer wish to receive a score. And the practice is accountable to support the patients regarding their next steps of their risk score. The transparency elements that are important. We want to make sure that, as I mentioned earlier, that we have shared the historical data that we utilized for the risk score. We need to explain the risk score in great detail so they understand what it means, how to interpret it, any limitations of the model, and all the attributes that we actually use in there would also need to be explained in a way that a layperson can understand. And that is all I want to cover today. I look forward to feedback. Thank you.